So what we're going to do this morning in this session on practical approaches to community partner dissemination, implementation, improvement research is first just give a little overview or introduction, and then sort of open it up for a more interactive discussion. So we thought it was best to have the sharing occur across the people who are here, and have people ask questions and come and discuss real world experiences that different people in the audience may have been involved with, and Ellen and I will try to help facilitate that. But to get us started, Dr. Ellen Olshansky, who is professor in nursing science and the director of the UC Irvine Community Engagement Unit of their Clinical and Translational Science Institute, is going to give an initial orientation, and then there are a couple of figures that she and I will maybe use as sort of the framework for our discussion moving forward. So why don't we give her a warm welcome, Dr. Olshansky.
Thank you, Keith. Dr. Norris.
Keith is good.
Yeah, okay. So Keith and I just met each other, so this is, and so we've talked over the phone and planned this, and we both agree that because this is really a breakout session and the idea is to be interactive, that we want less on the lecture part and more on the interaction. So I'm just going to talk a little bit, but feel free to interrupt me even while I'm talking if there's anything you want to say, because we really want to emphasize discussion and do want to hear your experiences and your expertise. So basically, community engagement, and I don't know that this is so new to any of you. You probably have been doing this, but it's partnering between academia and community, or researchers and community members. Sharing a vision for constructive change is a big part of this, because it really is an action-oriented research approach. And there's a great importance of embracing mutual respect, trust, and open communication. And it's very important that in doing this kind of work, that we acknowledge the expertise of all members who are engaged in the partnership. And it kind of follows on what someone said at the end of the plenary that we just had about the importance of community members really being there and being at the table. Cultural competence is a part of this, embracing community members from various communities, learning from the community. From my perspective, because I come from the academic side of things, I feel really strongly that I need to listen and ask questions, be open to understanding other viewpoints, many other viewpoints. So why is this important? Community engagement and cultural competency are both essential to community-based or community-partnered participatory research. That we need strong relationships between academic members and community members in order for the research to be relevant, in order for it to make sense. I mean, why do it if we're not going to see results that benefit the health of the community? CBPR, community-based community-based participatory research. We keep changing names. I think it's Ken Wells, or maybe Keith, it's you who now call it community partnered, which makes a lot of sense. But the idea is that it's action-oriented research that involves an approach that's inclusive of all the participants, and when I say all, I mean researchers, and research I put in quotes, because I think that's like not a great way to think. I don't see this as we're going to do research on people. We are all together. We need to reframe this and talk about doing research in collaboration, all of us. So it's an attempt to empower those who have not been empowered, and focus on making constructive change. I feel like I'm sort of repeating myself, but these are important concepts. So the traditional definition of research may connote being examined or exploited. It's kind of a loaded word. And Ken Wells and Loretta Jones, who I know are great colleagues of Keith's, they have done some writing on this, and perhaps you have too, on this whole notion of what do we mean by research. So I love this phrase called PhDs of the sidewalk, which is people in the community who, again, it's that they bring their expertise. So it's really a co-leadership or a co-partnership. We need to take a stance of humility, acknowledging different perspectives on truth, valuing diversity of views, and struggling together to arrive at a shared interpretation, not come with the idea that we have one reality that we're trying to prove here, but we need to be open. So I thought this cartoon was a great example of the importance of perspective. I mean, it's kind of sad, I think, but yeah, you cannot. So here's on this Caucasian mom and son. The mom says, "It's freezing out. How many times do I have to tell you to put your hood up or you'll catch your death of cold?" And here's an African-American mom with her son. "I don't care how cold it is. How many times do I have to tell you to keep your hood down or you'll catch your death of trigger-happy vigilantes?" And I mean, this is a really poignant, profound example, but I think it really does reflect the importance of perspectives and understanding the different perspectives and meanings. I'm not going to go through this too much. I'm going to quickly go through this so we have time to talk. But there's 8 principles of CBPR, that the community is the unit of study. We build on the strengths already present in the community, collaboration and partnership in all stages of the research, and that we integrate knowledge and action. There's the we're trying to alleviate social inequality through co-learning. It's an iterative process, ongoing. It focuses on wellness and an ecological perspective of health, and that we partner not only in developing the research and doing it, but the dissemination of research findings as well, being co-authors. So I'm going to skip these slides because these were actually slides that were part of that, except that this one I wanted to add. Who is at the table is important, and I'm really glad you added, Keith, who is not at the table, who should be at the table. That is something that we need to think about as we do all of this. And so I'm going to go through these because I do want time for us to talk. So the guiding principles, this comes from the Healthy African American Family Study. This is also, and maybe you're involved in this too, because it's I met Ken Wells just over the phone. I called him because I was really interested in his work. I'm at UCI, which is just an hour south, and I'm actually relatively new in my position as Director of Community Engagement for our CTSA. So I called Ken just because I was really interested in his work. So that's and then I fortunately got to meet Keith through this conference. But the guiding principles that they have talked about is the co-planning, joint leadership at each stage of the research, having written agreements, and actually we'll talk about this on the slides that you have. So I won't go over it. In fact, I think that would be too repetitive because you've got a lot of good slides. Okay, I'll just quickly say, having ongoing vertical and horizontal communication so that there's problem solving along all parts of the process in all different directions and bi-directional, and all activities of the project should be transparent. And communication could take place in different ways, via stories, via music. We want to ensure that adequate financial and other resources are available to community members. In fact, somebody mentioned that at the plenary, that in academia, we're on a salary, but the community members aren't necessarily getting paid for anything. So we want to follow community values and timelines. The academic researchers are actually the guests in the community. So we want to strive for the highest standards of productivity, focusing on the strengths of all partners, academic and community, and again, the cultural sensitivity or cultural humility is so important. And learning the historical and social context of the community is important for doing this work together. There is a social justice perspective of community-partnered research. So again, it's inclusive, including all members in all aspects of the scientific endeavor. So there's a need for academic researchers who do this kind of research to communicate. Well, this is a whole other thing with promotion and tenure committees, because sometimes they don't get it either, and they just want us to be research machines and put out R01s. And maybe instead, it's more important to be out in the community and developing real, authentic relationships. So, and then, informed consent, we need to really, has to truly be informed consent. And these are just some discussion questions. We can think about this, but whatever you want to talk about, because we're going to go on to, okay, okay, should we, did you want to go over your slides first, or should we?
No, we'll go back to them later.
Okay, good, okay.
So I think we have some questions here.
Okay, well then, since Keith introduced me, I want to introduce Keith, because I don't know when we're going to get, you shall, maybe, anyway, Keith Norris is an MD, PhD, and is at UCLA. He co-directs the Community Engagement Unit for their CTSI. He's also a professor in the School of Medicine at UCLA. So, yeah, so anyway, these are some questions. Oh, yeah.
Horizontal and vertical agreement, as well as the privileges. So I didn't, you kind of went through them really quickly.
I know I did. I went fast because
I'm fascinated and I wanted to know more.
Yeah, and it has to do with the idea that rather than just a top-down sort of hierarchy, the way we normally work, that we need to have communication that may be top-down, but also horizontal, and we need to maybe think more horizontally, which is more collaborative. I think that we almost assume that organizations work with org charts where there's someone at the top and then somebody here reports to somebody here reports to. So it's sort of looking at that in a little bit challenging, that maybe there's a place for, I mean, in other words, we need to have clear lines of communication. And there's going to be hierarchies. I don't think they're not going to be there, but we're trying to look at more collaborative ways of communicating. That's kind of what, and the privileges. That some people are more privileged in terms of where they are in the organization, and that is, I think, a question that I'd love for all of us to struggle with. Really, I think that that's what we strive for in this kind of situation. Yeah.
Hi. You know, just looking at your initial slides, I could take those and edit it just a little bit and give an intro lecture on clinical methodology. I come from a background of mental health provision. And what I see, and one of the toughest things to get through to new students is it's not your goal to tell the patient what to turn into, is basically you listen to them, you find out where they stand now, you find out what their goal is and what the shape of their life they want to look like. And it's your job to help them assemble collaboratively a treatment plan that's the dotted line between where they are now and where they want to be. And I have a set of information, and they have a set of information, and where those two converge and they're in agreement, then you got something. That's the treatment plan.
Interesting.
And you be flexible as you get from here to there, because on paper it looks like this, but there's variables in real life, confounding variables, we know what those are. And you tune it as you go, and that's not failure. And I'm just looking at this and saying, this is exactly that, but on a macro level.
That's so interesting.
That same mindset, it's just a copy of that. I'm always looking for generalizations. I mean, that's what science does.
But it actually helps. It puts it in a kind of this larger framework.
Well, the notion is that we're already comfortable with that kind of thinking, is that as doctors, we don't come in and say, here's what you're going to do and you better do it.
Right.
You know, we say, well, what's feasible for you? I mean, one of my favorite pharmacists once said in rounds, the best medication is the one the patient will take. And it's the same notion here.
But not all doctors have that approach. Or take that approach with patients. Not all doctors, I say. So some come in and say, no, I have the information, this is what you need to do, this. And similarly, researchers, not all researchers come from the mindset that there are valuable insights that can be learned and understandings that can be learned from their patients, from members of the community, from individuals who are working in different agencies. And so one of the things that I think we want to help promote today through this conference is that as sort of the academic arm, similar to being the physician, you can really have added value to that which you're doing if you're doing it in a more collaborative way and working with the individuals who you're engaged with, be they the patient as a provider or be it the members of a community related to the community you're working with. And I think Dr. Katz, for those who were here earlier this morning when Dr. Katz spoke, he really touched upon that when he talked about implementing systems and systems of change within the Department of Health Services, many changes which he implemented originally when he was in San Francisco, but now here, and how having people who are working within the clinics and the patients who are receiving the services be part of the solution and getting insights from them and then implementing what seems rational and reasonable, and at the same time collecting information around it so that one can sort of evaluate and have the evidence to say it is effective, rather than doing a little pilot here, a little pilot there, and meanwhile people are suffering and time's going by, and who knows what happens at the end of the road. So really thinking about how to do it, how to approach science in a more collaborative manner, and from implementation science perspective, how to approach scientific principles per se that are both methodologic, but at the same time clinical or public health oriented, so it's actually actionable and things are happening at the same time, but we think about what methodologic rigor we want to put into assessing what's happening. So I think those are great points, but yeah, we frequently don't think about it from the same perspective as a provider patient, but in a sense, it is just taking that connection and ramping it up to a system level.
I'm going to ask you to multitask. While you answer my question, could you go back to the sidewalk PhDs? I grabbed my phone from charging to take the screenshot, and I was just out of time. And then possibly while you're looking for that, could you talk more about truly informed consent?
Oh, yeah, I know. I really went over that quickly. I did. So this is the PhDs of the sidewalk. The truly informed consent, where does that come from? We know why we have institutional review boards, and it's really important. I haven't. Okay. So we know why we have institutional review boards, and they're very important. Sometimes, though, I think that they've become so bureaucratic that then we have these consent forms, and we rush up. In a way, what I did, which was not good, is sort of how we do the consent form, and that's what you have your hand up. You want to say something? Okay.
In regards to so my name is Dr. Juanita Booker-Vaughns, and we always use, when we come together with community and academic, we start with the 3 E's, and that's for ethics, equality, and equal partnerships. Right. We come back, so that's what you're looking at when you're doing that horizontal and vertical line. So we're equal. Yes. And we come together as partners, and we establish that at an inception. And we build trust. The 2 leaders, Loretta and Ms. Aziza Wright, they would use symbols like keys. Ms. Aziza would use the keys, and they would symbolize trust, where they would show that we all have keys to this partnership, because we use a bus model where they say everyone gets on and off the bus. you know, because sometimes we have partners that need to get off,
Right.
and they get right back on.
Right.
You know, they have their keys, and we establish the relationships and the partnerships and understanding. And when she said the PhD of the sidewalk, it's those community people that have the experiences and the knowledge that they
absolutely.
come to the table
Right.
with. So we can't excuse them thinking that they're not equal because they do have that
Right.
that knowledge.
Yeah, no, that makes perfect sense, and I mean, I think it's a great term, and thank you for elaborating on it as well. And what I was going to say about the informed consent is that so sometimes the IRB committees really become so bureaucratic, and then we have all this language in the consent form, and we almost just do it quickly, the way I went through the slide quickly, and I don't know that people are truly giving their informed consent, because I'm not sure that they're given the opportunity to understand what it is they're consenting to. That's what I meant. Yeah. Great, great.
Dr. Norris was interim president at Drew. Loretta Jones and so as a result of that, we Dr. Norris is one of my mentors, and Loretta Jones is one of my mentors, and so is Ken Wells. And my name is Placida Williams.
Hi.
I'm sorry. Dr. Norris got on me because I didn't introduce myself last time. But anyway, I'm community faculty at Charles Drew, and I'm also on IRB, and I'm on advisor to Loretta Jones' advisory board at Healthy African American Families. And I'm one of those people from the community that deal with an issue, minus depression, and Ken Wells put me with the project design that he had on depression. And so I learned about my illness. At the same time, I learned about how to design a proposal, a project to get funding and all that. I learned all that. But what I wanted to say about the PhDs is we are now considered, we decided, all of us PhD, Deanne with the white hair over there, she's a PhD also. We are now community faculty at Charles Drew. And we came up with the title, we didn't want to have PhD because we felt that academia was not going to consider us too talented or of value if we said PhDs. So we call ourselves community faculty.
That's great.
And that's one of the reasons. And that's the one I can think of right now. And we get involved in everything. And if you were here earlier, I asked the question, do they compensate community?
Yeah, no, I heard that question.
Right, and because we bring community to the table, or you don't bring them, but you come and research community, but you don't give anything back to them. You don't give them any stats on what happened with your research. You don't include them in anything, but you want to research them. And then when they rebel against that research, you want to know why. Well, they weren't included until the end. So that's where we get into this traditional, we're trying to break the, I don't know what the word is.
The paradigm kind of.
Yes, and it's been very hard because you were talking about the IRB. I'm a community representative on the IRB. There was only 3 of us, and one has now left the state, so there's only 2 of us. And my fight on the board is some of them listen to me and some of them don't because we got all these doctors on the board. And as you can tell, I got a loud mouth, and I'm short, so I have to talk louder. And so I've been on the board now 4 years, and I'm starting to understand what I'm doing on the board. And so I asked a lot of questions because I don't understand. And I deal with the informed consent because if I can't understand it, I know the community can't understand it. And they get very frustrated at me. I don't deal with the technical issues of how much blood you got to give and how the stats, and I don't get into that because that's too much for me. But my true self is that I don't argue with them. I ask questions, but I watch their body language when they're answering me. And I watch how they skip over something. And I say, excuse me, I didn't understand that. They don't like that because the researchers are about money. I don't mean to put anybody down, okay? But it's not about money. It's about, to them it is. And they don't consider that this is a human being you're dealing with. We're dealing with people.
That actually was what, even though I did skip over that slide, that is what I meant. So thank you for saying
Thank you.
that. Yes. Thanks. I have to say, I just want to say this is a personal thing. I talked about cultural humility. I'm like very humbled being here. Like here I am talking about this PhDs of the sidewalk because I read it in the article that Ken Wells wrote, and then yeah, here it is. So thank you for it. Yes.
It's a little more, sorry, it's a little more, so I know you mentioned the community faculty, but it's not just a name that was given you. We actually at the institution at the time, we went through working with the appointments and promotions committee and with the dean of the medical school and created an actual track with a set of roles, responsibilities, and criteria with an academic boot camp for potential community faculty members to go through as part of their training, and then they have a faculty plan as does any other faculty member. Wow. So it's not just a title that's given, but it's actually a track, sort of like an adjunct faculty track. Great. But it has its own definition to it.
Really great. Yeah.
Just a quick question and follow up to that. So I'm currently an MPH student at UCLA, and I would love it to have some community faculty there. I guess, what is the plan to carry out or to expand something like community faculty at Charles Drew to other schools?
Great question. So it's something that we're thinking about. As a small, independent, private university, it's a lot easier to implement certain things than an institution like UCLA, where actually the faculty appointment and promotions process is part of the entire UC system. That being said, there are alternative structures and titles we can think about that can give an individual a level of stature as being part of the academic team per se, and so that's something that we, several of us have been thinking about, and we will continue to work on. But many of those individuals have been active in co-teaching within the Robert Wood Johnson Clinical Scholars Program for the last 10 to 15 years. So there's a history of activity and participation. There is some teaching that also occurs in collaboration with the School of Public Health, predominantly through the health services, through the Division of General Internal Medicine and Health Services Research. So that's where most of the linkage is right now between many of the community faculty and PhDs of the sidewalk are by and large coming through that division, and we work collaboratively on a lot of research projects. They're co-authors on publications, they participate on research grants, and they participate in the teaching as well. So we have to try to figure out at a more formal level what makes the most sense, and not quite there yet, but it's clearly something that's on my mind, and in part Loretta asks me every couple of weeks what's going to happen with that.
So I know that you mentioned that there are some like academic boot camps to orient the PhDs of the sidewalk into the organizational institution. Can you speak to whether or not there are like science-based training programs? I know that the CTSI at UCLA has a couple. Can you speak to some of the requirements or the successes of that program, and any like matriculants that have been successful in continuing their education and going forward to get the official title?
Sorry.
Maybe I don't want it on. So the academic boot camp, is helpful for giving people an understanding of the rubric for academia, and for accreditation purposes. The accreditation bodies want to make sure that people who are part of the faculty and participating as faculty have undergone some training, and so that there's some consistency in what's being delivered to the students and how students are being assessed. The concept of a community faculty per se is not new and limited to people who are engaged in community participatory research. There are extremely wealthy people. Take someone like Bill Gates. He didn't have a degree. I'm sure he has some faculty appointments in some schools of business around the United States. He does have a PhD at a sidewalk when it comes to business principles. So there are many people in the business community who are adjunct faculty at many business schools who do not have formal education or substantial formal education. They don't have the degrees per se in business. They didn't get an MBA. They didn't get a PhD in economics, et cetera, but they bring the skills that are crucial. So the academic boot camp helps to synchronize them with the training of the students per se. Now, as you said, from there, the question is, what are the opportunities for people who want to go further, maybe, and get additional training and take their career in a different direction and maybe become more formally integrated into an academic environment. So there, we don't have anything formal in place right now. There are different programs, frequently so depends on where people are. So some people have not completed high school. Other people already have master's or doctoral degrees. So there is a large range of people who are participating in many of the dissemination and implementation activities that we have at UC Irvine and UCLA. We try to make available for people who are interested in it, or at least try to help facilitate their getting into programs. Frequently we'll see, more frequently than not, we'll see people who want to get an MPH, but people may want to go forward and get a doctoral degree in one area or another. They may want to get an MD degree. They may want to get a PharmD degree, whatever it is. So we want to try to help facilitate and support them. We do not have any specific programs in place that do that, but we do try to help make sure that people that we work with within a lot of our research activities, that they know that those opportunities are there for them. They do participate in a lot of seminars, a lot of research projects, publications, co-authors on publications. Plus is on a bunch of publications now. Deanna's on a bunch of publications. So Juanita's on her way. Juanita just got her doctorate in education just a few months ago. So there's not a formal link, but we try to be supportive and do what we can to make sure that people's goals can be achieved, whatever those are, and during the process to make sure that they realize that that they should be thinking widely about what those goals might be and what those horizons might be, and reach as high as they want to reach, and then what we might be able to do to support them. Martin?
The Institute of Medicine, Martin Shapiro from UCLA, Department of Medicine. The CTSA review by the Institute of Medicine recommended, and I believe they've embraced the idea, that there should be meaningful community engagement at all levels of the research process, including the formulation of research questions and throughout the process. So this really does imply building community participation into the infrastructure, and not just at the moment where someone has the idea of a study and is going into the field and wants to have this community piece, which in itself is an improvement over not having the community piece, granted. But it implies a role for community in lots of things where it isn't occurring in any academic institution currently. It also implies participation in a way that's never going to get funded in grants. Now, how does one move towards having the kind of financial support for community involvement in such an array of essential activities, if folks are really serious about that level of involvement?
I don't have the answer, but it's a great question, and that's kind of also what I was alluding to in terms of promotion and tenure, that those aren't, sometimes this kind of work isn't as easily funded, and how do we do that? And so I don't have the answer, but it's a great question.
Well, I mean,
Yeah.
thinking about it, the universities get indirect costs to support their research infrastructure. If arguably the community participation is part of that infrastructure, I realize it would take an act of Congress, probably literally.
Right.
And, you know, and they don't pass any laws anymore. But, but an argument, I think a cogent argument could be made that that should be part of the infrastructure for any institution doing translational work.
I think it's a great argument. I agree.
I was trying to get the correct name. On April 14th at Charles Drew, we will be having a community academic networking forum. And so you're invited to come if you'd like to come. If anyone wants to come, you can see me after this or whatever, and I can give you the information. But it will be at Charles Drew, April 14th. And it's an open forum, so you can find out about what we do and whatever.
Well, I'll talk to you after, but can we go to the Charles Drew website? Will it maybe be on there?
Should be on there, right, Dan? It should be on the website, yeah.
Great, thanks.
Yeah, look up the, what's the Access Community Engagement, you know, but anyway, it should be on the website.
Great, thank you.
Yeah. Accelerating Excellence in Translational Science. It's a sort of CTSI-like program for minority institutions. Dr. Brooks, you have anything you want to add, say, question, answer?
I know Dr. Norris from way back, stories I will not relate. But as it relates to IRB, there's almost a fear in the community, in a community-based health center of the IRB. Unnecessarily so. In other words, I don't have it. So could you just briefly describe how we can make that concept more palatable, how we can feel more comfortable knowing that we're going to do research? I read that Drew had a poster board in there that they did an obesity program and they had to go through IRB, and not every patient accepted it. So just briefly address the concept of an IRB in a community-based research program.
Plus, you're an IRB. Anybody else here a member of the IRB at their institution? Want to answer that? Henry?
Yeah, I don't know how to answer that. I mean, that's a tough question. You know, there's some historical issues that have taken place, especially within the minority communities, having to do with research. And there's, I mean, you know, that's not going to go away anytime soon. That lack of trust, and so that's going to be a big hill to climb to try to explain to people that, you know, as researchers, you're trying to implement an initiative that at the end of the initiative is hoping to do some good in the community. That's why we're here. But it's that whole lack of trust and getting people to participate that's the problem. And I just don't know how to overcome that other than dialogue, continued dialogue.
One of the things that I did, because I had that fear too, I didn't know what IRB meant, which is Institutional Review Board. I didn't know what it meant. I didn't know what it was for. And once I got involved, I actually got in a clinical trials. And I'm an asthmatic, and I have a whole bunch of issues, but I'm an asthmatic. So I got into an asthmatic clinical trial. And so I went through the process of reading the documents of what they were going to do and whatever. And the doctor said, "How do you know so much about this?" I said, "I'm on the IRB at Charles Drew." And he was like, "I just left there. I was talking to the doctors there and blah, 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 blah." But so that's what I did to get over my fear and my understanding. And then, like I say, on the board, I asked all kind of questions. And I learned the history because we have to take the CETA, the city. We had to take those tests. They're tests to me. And we had to go through, we had to learn everything about, I had to learn everything about IRB. And I learned about all of the stigmas and what happened with the Tuskegee Institute, the patients, what happened with the Willowbrook study, everything. I had to learn all that. And I'm not going to quote it because I'll get it messed up. But anyway, that's how I calm my fears. And so when I talk to people now, I go out because African Americans, Asians, Latinos do not get involved in clinical trials. They don't get involved for whatever reason. And so I'm trying to let them know that a lot of medications don't work on us because all the studies have been done on Caucasian. And so one of the things that I use is diabetes. You know, the medications just don't work on African Americans like they did on Caucasian people. So, not all of them, but some. And so that's what I do. I use personal experience. I truly do bring to the table personal experience. I'm not ashamed to talk about, I deal with depression, I deal with asthma, I deal with fibromyalgia, all this other stuff. And so I'm trying to break those myths, and I'm trying to get people to be comfortable with who they are, to be transparent. And that's what the
CBPR.
Which I'm supposed to know, but I'm not even saying it. But the community participatory
research.
That's it. Sometimes I get tied to, and that's what it means by that. We have to be involved, and Dr. Norris, Dr. Wells have made me comfortable to get involved in the studies, the research that's going on, and it has taught me how to deal with myself and learn about me.
Yeah. Well, one thing, and I'm just thinking of it now, 'cause that's a great question, and Dr. Shapiro was just saying that it's important that we really think about having community engaged through every part and every component of the research process. But even when there's significant involvement, the piece that probably has the least involvement in the most involved projects is the writing and the developing of the IRB submission and the informed consent. And so we probably need to rethink how we make sure we have more community, or I would say whatever our project is, that our partner is actually at the table involved in putting together the informed consent proposal and thinking it through. So that way, all those issues are at least better addressed, if not so, but they would be better addressed, and then and then making sure that that information about that process goes to the IRB. So when the IRB looks at it, they may have their viewpoint, and it's important that they do look at it, and it's important that they have their viewpoint, but it's also important that they understand that that informed consent was developed jointly by the research team, the partners, with input from likely recipients or participants in that research project. So as I think about a lot of the work that we do that's really partnered research, I would say that is got to be the area with the least participation and probably in need of having the most participation. So I think it's a great point you bring up, and something that, as a take-home point for all of us here who may be doing that, something we really need to think about.
Hi, this question is going to be a little off because it's not based on research, but I'm working with I'm an MSN and PH student, and I'm working with the Black Infant Health Program for Long Beach Department of Public Health. And I have been tasked with reaching out to the Black community and getting more people to enroll in this program because the funding is based on how many African American births are in Long Beach. And the problem that I seem to be having is that a lot of people who live in Compton and Lakewood or surrounding areas deliver in Long Beach, but they don't live in Long Beach. So, I mean, the ideas that I've come across have been, you know, churches, grocery stores, things like that, get the information out. But if anyone else has any other suggestions of how I can go about reaching the people, I'd appreciate it.
That's good.
Community, so.
Yeah.
I'll beat you 1 second, Juanita.
Okay, hi. I used to work at Daniel Freeman Memorial Hospital, so I'm accustomed to being the minority, the little white doctor running around the hospital. And it was a pleasure. I mean, I learned tons. But, you know, I don't have a specific recommendation for you, but I teach research methodology, and I'd say snowball sampling is ask whoever says yes to you, do you know of anyone else or any other organizations that might be interested in something like this, that this would be a real service to? Because the more we can rope in, the more people we can help. And if you keep phrasing it positively, that you want to do help for them, not help yourself recruit, you want to provide the service to them. So frame it positively and always ask at the tail end, do you know of anybody else who, and then name off your criteria, who might be interested in benefiting from this? Say it like that. And ask them, and who else at the end of everything. And let the list run out. Don't just stop with one. And you're asking about people, organizations, families. Help them broaden their thinking so that your snowball sampling inquiry has as much power as you can get, and you'll have sample up. You'll get what you're looking for.
Yes, I'm an educator, so I would have to say you can go to those school systems and preschool, Head Start. There's so many preschool programs in Long Beach, the CDC's Head Start, and private entities where you would probably find these parents and families that are living in Long Beach. The children were born in Long Beach. There are also other community organizations that are right there in the heart of Long Beach. Your agency is downtown? Where is it located?
Where? You said what street is it on?
It's in Long, okay. Well, I know Long Beach, and I even taught in Long Beach, and I have a lot of friends that are principals and all that stuff, so maybe we can talk.
Any final questions or final comments? It's close to 11:30, so we'll give
I was just going to make one final comment for Ms. Williams. I don't think you should worry at all about trying to remember all the many-syllabled words. I just got involved in this. I'm really a community organizer who's trying to learn this whole thing. And I got involved with a group, SERP, and they sent me the invite, and I was free today. And my husband last night was like, "Where are you going tomorrow?" And I was like, "I don't know. It's like 6 words in there. I don't even know what it means. But these people are really good that invited me." And so I felt like that is a barrier in itself. Like, you could just call this the share, do, and get better, get together. You do not have to call this the dissemination, implement. And I was like, really? Implementation science is just do and not put it on the shelf? So I just want to say the way we think about it is you're a contextual expert. Nobody knows the reality of what you're living better than you. And if you really want to make change, you'll listen to the contextual expert, because change goes as fast as trust. If you don't have trust, no one's going to change anything. So I just want to, thank you for what you shared today. Stand in the truth of who you are. And I don't think it's a lack of our knowledge. I think also our partners need to think about, could we put this like in real English? Because, I think it would create a wider net of inclusion.
No. I think we'll end there. Let's have a big round of applause. Thank you.